predictability. The milkman, the paperboy, evening TV. Did I get delivered here? Somebody tell me, please.
I am doing AP toes today, so I got my 10 by 12 IR set lengthwise. I collimated down since the toes are a small field, and from there we'll collimate down closer once we get our patient. I have it lined up to the center here on our IR. I have the SID set to 40, and we will go grab our patient. All right. Hi, my name's Alexis. I'll be imaging you today.
Hello.
What's your name?
McKenna.
And then is there any chance you might be pregnant today?
Nope, not one bit.
All right, if you want to follow me, your shoes are off. Perfect. Come on in here. So I'll have you sit on the table for me. And then what's your foot that's having a problem with you today?
This right
your right
one.
foot. If you want to take that sock off for me, that would be perfect. Thank you. And I'm just going to bring the table back up to working height. We keep it down to let the patient on his knees. Okay, so our patient is on the table. She has her foot out. So I'm going to have you place your foot flat down on the table here. And then I'm just going to help kind of guide it back. So we're going to kind of slide the foot back a little bit. Alrighty. And you said it was your third digit for your toe today?
Yes.
Okay. So we can collimate down quite a bit because it is a very small toe. We don't need the whole thing on there. We do want our distal metatarsal to be present. So I will include part of the distal metatarsal. And we want it centered to be at the MTP joint. So it's the metatarsal phalangeal joint. And everything looks straight. I'd have her try and separate the toes just a little bit if she can. Not everyone always is able to very great, but try and have them do it as much as they can. Again, foot will be flat. She's sitting straight on the table. Make sure the IR hasn't slid at all from having her foot on it, so everything still looks all centered. I will then grab a shield. And I'm just gonna have you kind of wrap this right around your legs here on your lap. This will help protect the patient from any unwanted radiation. So my patient has shielded. I have them centered. There's a 10-degree tube angle for the toes. So it's towards the calcaneus, which is the heel. And this will help open up the joint space to be imaged better. So shielding, patient shielded. Technique, 55 at 2.4 mass. Angles, the 10-degree towards the calcaneus. We have a marker. So since this is her right foot, I'll be placing my right marker in the collimation field. And if you need to kind of turn it in to get in to the image, that's great. If you need to open up collimation a little bit too to make sure it's in there, feel free. You just want to make sure you still have that distal metatarsal in there as well though. And then positioning of parts. So again, centered to the MTP joint, the metatarsal phalangeal joint. And I have a 40-inch SID. I have her for breathing. She'll be just holding still. Don't move, you don't have to worry about not breathing, but just hold still. And then collimate to size. Again, collimate down as long as the distal metatarsal's in there and you're not clipping any of the toe. So as long as that's done, you will be all good for your imaging.
So this oblique medial rotation of the toes. You're going to want a 40-inch SID, and your CR should be at the first MTP joint. Make sure you have the correct collimation, right foot, right marker. Make sure your patient's foot is rotated 45 degrees inwards. You're shielding, and this is going to be 55 at 3.2 mass.
I have my patient in a lateral toe position for the first toe. You're gonna have your CR at the first IP joint. Your SID is gonna be 40 inches, and you want to have these toes out of the way so they don't get in the way of the x-ray. And your technique is gonna be 55 kVp at 3.2 mass. Make sure you shield your patient, and then you're good to take your image.
All right, so I will be doing the AP foot today. We start out 40-inch SID, 10-degree tube angle towards the heel. So I'm going to have my patient, she has already placed her foot in the center of the IR, like, all right. I have her centered around the base of the third, so you're basically cutting the foot in half. I'm gonna open collimation a little bit. We have our 10 by 12 IR. Making sure we're getting both malleoli. And then, this is the right foot. I'll be putting my right marker in there. Now I have my patient shielded. Make sure she wasn't pregnant prior or anything like that. Our technique will be 55 at 4.5. Yeah. Breathing, just stay still, don't move. And we're collimated.
This is my AP oblique medial rotation foot. I'm going to start by shielding my patient and having my patient just sit up like this. My sit is going to be at 40 inches, and I'm going to use a 10 by 12 IR lengthwise. Since this is a medial rotation, I'm going to go ahead and rotate her foot 30 to 40 degrees, and that should leave my CR to be at the base of her third metatarsal. I'm going to line up the lines with the IR, and then I'm going to put my left marker on her lateral side, since this is her left foot that's affected. I'm going to make sure she doesn't move, doesn't breathe, and my technique is going to be 60 kVp at 4.5 max. Lateral foot. So I've got her positioned with the lateral aspect of her ankle against the board, the IR. I will grab my shield, place it over her lap. I have a 40-inch SID with collimation down slightly. We have to have at least 1.5 to 2 inches of the ankle joint, and we have to include the toes. Then this is her right foot, so I will put my right marker in the collimation. And my technique is set on the console for 60 kVp at 4.5 max. I will have you sit still and don't move to your best ability. Alright, so the next projection is the plantar-dorsal axial calcaneus. So to start off, I have a 40-degree tube angle towards the base of her foot. I am centered at the base of the third metatarsal at a 40-inch SID. I have her dorsiflexing her foot right now. I will place my right marker, not in the anatomy. My technique is set on the console at 65 at 20. And I'll have you pull your foot back as far as you can, don't move, and then take the exposure.
I'm
going to start my patient off in a supine position, and her left foot is going to be her affected foot today. So I'm going to go ahead and just roll her body over, and I can go ahead and shield her. This is the medial-lateral calcaneus. So I'm going to go ahead and send her calcaneus to the IR. And then my central ray is going to be 1 inch below her medial malleolus. And I'm just going to adjust her foot so it's in a true lateral. And my SID's going to be at 40. I'm just going to tell my patient to don't move, don't breathe, with my marker on the correct side of her body. And my technique is 65 kVp at 5 mass. And B. This projection is the AP ankle. So I have her heel against the board on my 10 by 12 IR. I am centered midway between the malleoli with her foot dorsiflex. My SID is 40 inches and there is no tube angle for this. This is a right ankle, so I will put my right marker in the collimation. I have my patient shielded. I'll have her dorsiflex her foot as much as she can, and then don't move. And my technique is 65 at 5 set on the console.
Okay, for the AP Mortise medial rotation ankle, I have a 10 by 12 IR lengthwise, a 40-inch SID with no tube angle. My patient is shielded, and I have their foot centered on the IR with their toes slightly pointed up. And then I'm going to rotate the whole leg medially 15 to 20 degrees. And then we can collimate side to side and have our marker in the collimation, but leave it open at least 10 inches to include the lower leg. Okay, technique is set at 65 kVp and 5 mass. And then I'd ask them to hold still as much as possible and take the image.
So today I'm doing an AP ankle. This one was medial rotation. So with this, the ankle is going to be rotated 45 degrees in. This is done by rotating the whole entire leg inward. And then we are going to be centering between the malleoli. So you'll find the lateral and the medial, and you'll go right in between, and you want to be cutting the ankle in half. And when you keep it open, collimation is going to be open lengthwise because we want up here in the joint. And then I did collimate side to side. We do not need to worry about the toes. So if you're clipping up at the toes, that's completely fine. I have my patient shielded. We're currently at 40 for our SID. So I have my marker placed laterally on the foot here. We have it within the collimation. And I would have my KVP set to 65, and I would have my mass set to 5. And I would just tell my patient to hold still, don't move. And then we'd get behind the barrier and expose her.
I have a lateral ankle, and we are doing the right side. So first I'm gonna put the shield on, and I'll have my patient roll up on her side. And we are gonna center to the medial malleolus right there. And then line up our 10 by 12 lengthwise IR. And then we will shield. And we'll have her hold this position. And our technique we will set at 60 kVp, 5 mass. And we'll take our image. For an AP lower leg tib fib projection, I have a 14 by 17 IR lengthwise, 4-inch SID with no tube angle. Patient is shielded. The technique is going to be 65 kVp at 5 mass. And I have them with their leg extended. And I'm going to ask you to point your toes towards the ceiling so that they're dorsiflex. And have collimation open as far as you can to include both of the joints, and then you can collimate side to side and add in your marker, and then ask the patient to hold still as much as possible and take the image.
So I have the lateral medial lower leg tib fib. My SID is 40 inches. We have a 14 by 17 IR, but we're going to collimate via widthwise. We are going to do 65 kVp at 5 mass, and then we're just going to cut the tib fib in half, and then I'm going to put my right marker on the outside and have her dorsiflex her ankle and beat. Okay, so I have an AP knee. We're using a 10 by 12 IR again. It's tabletop, and we are centering roughly 3/4 of an inch below the patella. So I have that right about here. Feel a little patella. And we are gonna leave it open the full 12 inches lengthwise and just collimate in maybe a little bit, not too much. And then we're gonna add our right marker, just wherever we can kind of squeeze it in. We are at 65 at 5, we're shielded, 40-inch SID. Just please hold still.
So this is a medial internal rotation of the knee. So you want a 40-inch SID, and your shielding will be placed right here, and your right marker will be placed anterior or laterally. And then for technique, it's going to be 65 at 5 mass, and you'll want to rotate the knee or leg 45 internally.
Alright, so I've got an AP external oblique knee. So first we'll have our patient be on the table and we will line up the IR underneath the knee and rotate her leg to be 45 degrees. And I have my right marker since this is the right leg. And then we'll move over and put our shield across the patient's lap. Our technique will be 65 kVp at 5 mass. We have a 40 SID and we will take our image. Okay, I have a medial lateral knee. I have a 10x12 IR lengthwise and a 40-inch SID with a 5 to 7 degree tube angle towards the head of the patient. I have her laying on her affected side with her unaffected leg over for patient ease. Technique is set at 65 kVp and 5 mass. And then the centering is 3/4 of a quarter below the apex of the patella. And I've made sure that the patella is sticking straight out to ensure that she's actually lateral. Collimation is kept pretty open so that we're not missing any anatomy. And I have the right marker within the collimation and the patient is shielded. And then I'd ask them to hold still as much as possible and then take the image.
I'm doing the camp commentary method. You're gonna make sure you have a 40-inch SID. Your angle is gonna line up with the angle you have set on your patient's leg. You're gonna mark the correct side on the lateral side, so it'd be a left leg. And then your technique is gonna be 65 at 6 mass. And make sure you shield your patient, and then you're ready to take your image.
This projection is of the intercondylar fossa. This position is the home blab position. So I have my patient prone on her hands and knees. I have a sponge under her good knees for patient ease and comfort. Over here I am at a 40-inch SID, no tube angle. My CR is perpendicular to her popliteal crease. My technique is set at 65 at 5 on the console, and I would have her hold still to her best ability and take the exposure.
For the AP axial Beclaire method, I have a 10x12 IR lengthwise, a 40-inch SID. I do have a tube angle, but it's not set. You have to match the flexion of the knee. And I have my patient shielded. Technique is 65 kVp at 5 mass. I have the patient laying down on the table with their affected knee flexed about 40 degrees. And then I have the IR sitting on a tissue box to reduce OID. The CR is 1/2 inch below the apex of the patella and then collimated in side by side. And I have my right marker in the collimation. And then I just ask the patient to hold as still as possible and then take the image.
I'm doing the Rosenberg method. You gotta make sure you have a 10-degree caudal angle, and you're gonna point your CR at the crease in the back of their knee. Make sure you have a 14 by 17 IR crosswise. You still should do patient, just make sure it's not in the light field. And you're gonna have them stand on a stool, bend their knees against the bucky and rest it up on it, and hold on to it. Still 40-inch SID. Your technique is gonna be 65 at 6 mass. And then you will take your image.
So I have the infrasuperior projection for a sunrise view, which is for the patella. We are going to show you how to set this one up because it can be a little difficult. So we're going to bring the tube all the way over here. And we're going to angle it. And then bring it all the way down. Make sure the toes aren't in the way. And then we are going to angle it to match her patellofemoral joint space. I'm going to give her the IR. We're going to have it crosswise and just make sure mid-thigh level. And then we're going to have her bend her knee until her patella pops out. So right there. And then we're just going to match it to wrap it around. And then we're going to collimate down. And then we're just going to line this up.
And then we'll put our marker on. And we are going to make sure our SID is at 40. So we have a 40-inch SID now. The CR is cutting in the joint space, wrapping around, and you can see the patella right on top. We have our right marker in the light field. This is going to be 65 kVp at 5 Mass. We're just going to have her hold still and beat.
So this is the Houston method. So for the leg, you're going to want to flex it like 50 to 60 degrees. And they're also going to be prone. The shield is going to be right on his back. You'll probably want to have an 8x8 collimation and then a marker on the lateral side. And then you're going to have a tube angle. It just depends on the angle that you have flexed. So 55, 60. And then for technique, you'll do 65 around 5 to 6 Mass. Yeah, that's it.
Alright, this is the set of gas view, prone position. We're gonna have a 40-inch SID with a 15-degree tube angle. Make sure it's valid. You're looking for the patellofemoral joint spaces. You're gonna collimate to size. Make sure you have the correct marker. It's gonna be a 10 by 12 IR with crosswise. You're gonna give your patient a band to hold their foot back as you do this position. Give them shielding, and this is gonna be 65 at 5 Mass.
So I'm doing the seated setagast view today. This lets us see the patellofemoral joint space of the knee. This is also known as the skyline view or a sunrise view. I have my patient holding the IR as best as they can, as still as they can, and then it will line up to the joint space. I have it matching the angle roughly of our tube, so our tube has an angle of 15 to 20 degrees. I have it set to 15 right now. And I have my right marker placed up out of the anatomy. I have the knee joint open so we can see down into the knee. You want to see past the knee. I have my KVP set at 65 and my mass will be set at 5. Our SID is 40 today, and I would tell my patient to hold still. I have them shielded, and I would just, again, hold still as much as you can and then go back and take my image.
I'm positioning for a PA patella right now. You use a 10 by 12 IR lengthwise. You're gonna position your CR on the crease, and you can collimate down because the patella is very small. And you're gonna shield your patient, 40-inch SID, and your technique's gonna be 60 kVp at 6 Mass, and then you'll take your image.
This is a medial-lateral patella. So at first you want to get a 40-inch SID, and you'll want to have to get a 10 by 12 IR lengthwise. And then you'll want to bend the knee 5 to 10 degrees. So bend that knee, and then make sure you put your marker lateral too. And then for collimation, you're going to want to do an 8 by 8 instead of a 10 by 12. And then for your technique, it's going to be 65 at 5 Mass. And your CR is going to be at the patellofemoral joint space. And then the shield will be right over him. And then, yeah, that's it.
I have the AP unilateral hip. We are in the bucky. We are detented at 40-inch SID. I have my right marker on the correct side out of the anatomy. So for our CR, we are going to the mid-femoral neck. To do this, you're going to feel for their ACIS, go 2 inches medially, and then 4 inches down, and then we are shielding on the opposite side out of the light field. I have the patient roll their legs inward until they are APTP or until their toes are connected, and then my sit is at 40 inch. We are going to do 75 kVp at 12 mass. Hold still, don't move, beep. So I have a unilateral frog leg hip. So we are centered 2 inches medial from the ACES and about 4 inches down, but you might be a little bit higher up on this one just so you can get the top of the crest. We have a 10 by 12 IR in the bucky in the drawer, and then we have our marker in the drawer. You can do it tabletop, in the drawer, whatever fits, just as long as you have a marker. We have our right marker, and we have our patient's leg bent. We want to try to get it close-ish to the knee, and we are at 75 at around 15 mass. We have the side shielded that is not our side of interest, and this is just hold still.
So today I have an AP proximal femur, and so first I'm going to have my patient flat on the table on her back, and I'm going to have her put her toes together like a teepee, and we are going to put our central ray to the middle of the IR, and where we have a little bit of film above the crest, and we're going to have a 14 by 17 IR with a right marker because we're demonstrating the right side. And we have collimated in crosswise. And then we will shield our patient as best as we can. Then I'll have you hold it. And we'll have our patient hold it, hold still, and don't breathe. And our technique will be set 75 kVp at 15 minutes. And we'll take our image.
So this is the mid to distal femur. You're going to have a 40-inch SID. You're going to make sure your patient is shielded in the abdomen area. And you're going to want a 14 by 17 cassette. Make sure you have the correct marker on it in the bucket. And the CR is going to be in the midpoint. Make sure you have 2 inches below the knee joint for collimation. And this is going to be 70 kVp at 8 mass. And stay still, don't move.
Okay, we have a unilateral frog leg proximal femur, very similar to the frog leg hip, but we're just centered down a little bit more, still 2 inches medial from the ACES, but we brought it a little bit more down, about 4 inches, give or take, just depends on the body type. If you have someone a little bit shorter, you're not gonna be able to go down all 4 inches, but we still have a 10 by 12 IR with our marker in the bucky, and our technique is still gonna be around 75 at 15. We are shielded, 40-inch SID, and just hold still again.
I have a lateral femur. So first we're going to center at the mid femur we're going to visualize the knee joint, make sure it's in there. And then we are going to use a 14 by 17 IR with our right marker because we're demonstrating the right side. We're going to have a 40-inch SID and have our patient shielded. And we are going to don't move, don't breathe with 70 kVp at 12 max.
Okay, so this is the Dan Miller. This is usually known as one of the trauma views. My patient's in a recumbent position with her leg in a leg holder. So right now we're looking at her left leg, and my IR is in a crosswise orientation centered to her femoral neck. So what I do is you move the tube and put it as close to a T and perpendicular to the IR as possible. I have my marker out of the way of anatomy because we're looking at her femoral head and neck. And my technique for this is going to be 80 kVp at 80 mass. I'm going to tell my patient to don't move, don't breathe, and then we'll take our image.